My name is Michael McGonigal. I'm the director of the trauma programs at Regents Hospital, and I'm going to give you a crash course on how to put in a trauma chest tube. There are a couple of things to think about when you're doing this. First of all, it has to be fast and it has to be safe. The people who will need these are those who have either a significant hemothorax or pneumothorax that absolutely has to be drained. There are a few things that you need to do to make this go smoothly. First of all, prepare your area, which means get all the equipment that you need, get your chest tube insertion kit, the appropriate tubes, make sure you have good helpers, trash cans, etc., so that you can do this very smoothly and without interruption. The next thing you need to do is to prepare the patient. And in order to do that, you need to explain what you're going to be doing, get consent, confirm the side that you're going to be putting it in so that there are no mistakes made, and then make sure that they have adequate analgesia and sedation. My preference is conscious sedation because these do tend to be fairly uncomfortable procedures. Things to think about, first of all, are what size tube are you going to use? And in the trauma world, we have only two sizes, big and bigger. And the reason for this is that most of our trauma chest tubes involve blood in the chest to some degree. And if we put a smaller tube in, it typically will clot these off and then your tube becomes non-functional. So in this case, what I'm going to do is insert a chest tube into our trauma simulator, and we will assume that we've done all of the prep work. I am properly gowned and gloved, and we are ready to go. So what we'll need to do is to drape off the field so we can keep it sterile, and we just use some sterile drapes. Now as you do this, it's important to make sure that you keep track of the nipple. The nipple has to be prepped into the field so you can identify the position where you're going to place it. There are two different ways that you can identify the proper position. Ideally, you'd like to put this in the fifth intercostal space in either the anterior axillary or the mid-axillary line. In men, you can identify the fifth intercostal space. It's the soft spot right under the nipple. You can put your finger in it and then just move right around, follow it to your anterior or mid-axillary lines. In women, it tends to be more variable, and an easier way is to find the xiphoid process and then move straight down the chest wall to the appropriate position. But for most people, just placing the towels such that you can still see the nipple will allow you to make sure that you get the proper placement. So, what I will do is just abbreviate this so that we can get some good capture of it, and I'll leave this wide open down here. So the first thing is, in an awake patient, make sure that you freeze up the area with some xylocaine so that you can make sure you've got some good local analgesia. And then choose the knife that you are most comfortable with. I tend to use a 10 blade. Some people swear by 15 blades. So find your fifth intercostal space, and I'm going to use the anterior axillary line. I make an incision that is perfectly transverse, which means it will be up and down with the patient lying on their side. And so I'll make this so that it's big enough so that I can put one finger in. My finger is bigger, or at least as big as the chest tube, and if I can get my finger into this incision, then I'm doing a great job. Once that is taken care of, then you need to take an instrument, find where you're going to be moving, where you're going to be inserting the tube. So you insert your finger, find the top of the sixth rib, right below in that space, and then once you've found it, insert your clamp, push, and spread. And what you're doing is slowly moving through the soft tissues and the muscle tissue right on top of the sixth rib. So you keep doing that over and over until you feel like you're down near the pleura itself. And you can confirm where you're going just by putting your finger in periodically and making sure. And once you're very, very close to being into the chest, then it's time to switch gears. Now you have to get ready for your tube. Now, in preparing the tube, what you need to do is to get it mounted on a clamp so that you can actually push it through the hole that you're about to make. So I'm going to mount it, and I like to mount it on the back of a clamp because whenever I release it inside the chest, I want it to pop away from the clamp. If I turn it around and mount it the other direction, when I release the clamp, it just sits between the jaws. And when I pull my clamp out of the chest, I may inadvertently drag this out. So what I'm going to do is to get the clamp all set on the tube. I'm going to actually make my puncture into the chest at this point. Now, one key thing is it's all too easy to push and puncture and keep going and sink the clamp in all the way, which you do not want to happen. So what I'm going to do is I'm going to grab the clamp with my other hand about 2 to 3 centimeters away from the chest wall, so that as it pops through, this will stop me from going through too far. So I've got it there, I push, and you'll feel it pop through. And then what I do is I spread and pull it out with the jaws completely spread. What this does is it makes sure that the pleural opening is as big as the skin opening. So now I can once again put my finger in, and now I can feel that I'm in the chest. I need to make sure that there is no adhesion between the lung and the chest wall, because if I insist on putting a chest tube when it's all scarred inside there, I can create some significant problems. And the other thing I'm doing is memorizing what direction my finger has to go and what direction the tube will have to go whenever I insert it. So I'll take my prepared tube, and the other key thing, since there probably is going to be blood in here, is I like to snap a clamp on the back end of it so that if there is blood, it won't go shooting out and hit other people in the room. As I'm getting ready to insert this, I have this nice vertical incision here, and if you look at the very tip of the tube, whenever I have it clamped, it's nice and vertical as well. I need to keep that orientation. I don't want to twist it, so I'm trying to put something that's wide through a little slit. So I keep the orientation, and I'm going to push it through in exactly the same direction that I memorized, and it should pop right on through. And then I can use the clamp to direct it upwards, which is my preference. So I'll just kind of push it upwards into the chest, and then hold the tube and pull the clamp out. Now what I can do is insert the tube as far as I need. And what I'd like to do is to make sure that the last hole is inside the chest. And typically in most people, this is about 10 to 12 centimeters marked on the outside. If you have an obese patient, you may have to put it in deeper, meaning that the numbers may go up to 14, 16, or even higher, depending on how deep the wound is. And then the final thing you do is check your tube position. There are two things that you can do. You can release this clamp, and as the patient breathes, you should see fog appearing in the tube with every respiration. And you can check to see if there's a kink by spinning it like this. If there's a kink in the tube, instead of it spinning smoothly like this, you'll feel resistance, and then it'll suddenly pop. Resistance, and it'll pop as the end of it flips around. So this one feels great. So at this point, it's time to do two things. Secure it so I don't have to hold it as much anymore. And that's just a typical suture, and I typically like to use one stitch at the very top of the incision, and then I wrap it around the tube and tie it. And then you have to get it plugged into the collection system. And for some reason, all the chest tubes come with this very sharply beveled edge, which does not fit the connection system to the chest tube collection. And so what I tend to do is to cut this little tip off, and once I've done that, the Christmas tree will work very nicely, and it'll plug right into this end very, very quickly. And the final thing most hospitals will do is they'll secure this with a little banding gun so to make sure that this connection never falls apart. So that's insertion of a chest tube, quick and dirty crash course. And then you can also look at the video that we have on how to take these out once the time comes. Thank you.